This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megur, and she's a 10-year-old girl who presented with this wide, mature, intumescent cataract, and there's a history of a penetrating injury which she sustained about 15 days back. On close examination, a corneal scar is very much evident. And this is probably the entry site, and the antechamber is shallow in one quadrant, and there is fluffy loose cortical matter coming out through the lens, and there is a clear demarcation line, and this is the region where the anterior capsule is probably torn, and this is where the lens matter is coming out from. And so we have a situation where there is definite evidence of an open posterior capsule. The state of the posterior capsule we don't know, but this is how I'm going to plan a surgery for this eye. Currently, I'm not aware of the posterior capsule status, but being a traumatic cataract, we need to expect the unexpected. So I'm ready with my anterior vitrectomy setup, that is the cutter, triamcinolone acetate, and dispersive OVD to deal with any posterior capsular tear if at all it's present. The plan is to stain the capsule, aspirate all the cortex, then trim the anterior capsule to get some sort of a rhexis, and then place lens in the bag. So I've taken multi-piece lens for this patient simply because the same lens can be used both in the bag or in the sulcus in the worst case scenario. So that's my plan, and let's see how things turn out. The side ports are being fashioned using MVR blades. The surgery is being done under IV sedation with a supplementation of posterior subtenuous anesthesia. The capsule is stained, and we can now clearly see the demarcation of the anterocapsular tear. I want to go ahead and aspirate some of the fluffy cortex which has already come out into the antechamber so that it gives me better visualization. I'm using bimanual I&A to do the job for me. Once the cortex which had come out into the antechamber is aspirated out, the OVD is replenished into the eye before taking the irrigation handpiece out. The antechamber is repressurized with the dispersive OVD followed by creation of the main 2.8mm incision. This is primarily for implantation of the lens. By cutting across the torn edge of the antecapsule using a micro scissors, I'm creating a flap, and this flap is grasped with the forceps to create capsular opening in the intact capsule. This opening would be around 5mm approximately. Obviously, the other end of the capsulotomy opening is gone up to the equator. The fibrotic band is difficult to cut, so I'm using micro scissors through the other side port to take care of this fibrotic band. So now we have a decent anterior capsular opening. So I need to deal with the remaining lens matter, and in small children, just the irrigation aspiration port is good enough to deal with it. So I'm using bimanual irrigation aspiration, and in just a matter of few minutes, the lens matter could be cleared off. So in a situation where there is a radial extension of the anterocapsular tear, we need to be conscious that this can propagate posteriorly to the posterior capsule and cause a posterior capsular tear. In this case, there is a fibrotic band which might prevent this from happening, but nevertheless, in such situations, always mandatory to ensure that the antechamber does not shallow at any stage of the surgery. So before switching hands, I'm going to inject OVD into the antechamber to prevent it from shallowing, and then the irrigation is taken out. The hands are switched, and the lens matter on the opposite quadrant is taken care of. It takes just a matter of a few minutes for the lens matter to be aspirated out. So in these pediatric cataracts, usually the lens matter is extremely soft, so they can be aspirated out in a jiffy. It's not an issue at all. There are a couple of fibers of cortex still refusing to come out. I'm just trying to irrigate and flush them out. I'm using cohesive OVD in the form of sodium hyaluronate to form the capsular bag, and my plan is to implant a multi-piece intraocular lens. And since the child is 10 years old, I'm not undercorrecting the lens power. I'm just putting the lens power which is actually calculated. The lens is then gently dialed in such a way that both the haptics are away from the radial extension of the anterior capsule. The cohesive OVD both in front and the behind the lens needs to be removed. I'm going in with my aspiration probe itself under the lens. The aspiration port is facing towards the optic of the lens, and then the sodium hyaluronate is gently being aspirated out. Traditionally, I just use irrigation whenever HPMC is there in the bag. But when we have a cohesive OVD, it takes more of a time. So it's better to aspirate it out, and there is always a risk of damaging the posterior capsule during this process. So you need to be extremely cautious and slow, and using very low flow rate and vacuum, you can carefully evacuate the entire sodium hyaluronate from the bag. And then the viscoelastic in front of the lens is similarly aspirated out. Now, since it's a child, we expect low ocular rigidity, and hence it takes some time for us to get the stromal hydration right and ensure that the wounds are watertight. So in an adult patient, you don't have to spend so much of a time in hydrating these wounds and checking for their integrity. But in children, they do take up some time, and in the event where there is some suspicion that the wound might not have closed adequately, it's always a good idea to put a suture. But I just wait for a couple of minutes and ensure that the wounds are tight enough. That's it, the case is done, the eye is patched. This was a case where, although I was very well prepared with the antivitrectomy unit and everything, nothing went wrong, and the patient just had an anterocapsular tear, which is relatively much more easier to treat with. Having said that, it's always better to be over-prepared than getting caught in surprise. That was it. Thank you for watching, and hope you found this helpful.